I can tell you that the first time I presented ground rounds, I was extremely embarrassed. They gave me a little laser pointer and I'm pointing it at the screen and I'm actually got the laser pointing at myself, but I had the wrong end. It took me like a little bit to figure it out. So as long as I don't shoot a laser pointer at myself, I think I'm doing a little bit better than my previous grand rounds. Um, all right, so this is where we were. The American College of Obstetrics and Gynecology recommends opioid agonist therapy for pregnant women with opioid use disorder. Um, there's a simultaneous rise in the incidence of newborns exposed to opioids and infants who develop neonatal opioid withdrawal syndrome. And this is the consensus statement from the American College of Obstetrics and Gynecologists. And the reason that they recommend that women maintain opioid agonist therapy during pregnancy, they say that is preferable to supervised or medically supervised withdrawal, citing high rates of relapse, which lead to worse outcomes. And in particular, these worse outcomes include death from drug overdose. So that's one of the reasons, that including that if you resume using IV drugs, there's also risk to the fetus in terms of infectious disease as well as endocarditis, bacteremia. So if women are in a medication-assisted treatment program, it's the current consensus statement that they maintain on those medications. I understand that there's active research looking at weaning women off of opioids during pregnancy, but this is currently where we stand. So this is a map of America, and the research that I'm going to show you at the end of it was conducted in North Carolina. North Carolina and Tennessee are the same color on this map. The darker you are, the worse or higher amount of birth hospitalizations with a diagnosis code of NAS. And then it says in parentheses, withdrawal symptoms due to prenatal exposure to illicit drugs per 1,000 birth hospitalizations. And you can see that North Carolina, Tennessee have fairly similar numbers. Virginia is slightly lower, and then West Virginia and Kentucky have particularly high numbers. Has anyone seen this report? It was published in 2020. If you are taking care of babies in the state of Tennessee that have a history of in utero opioid exposure, this is a really interesting report to read. And I promise I'll never tell you to read anything that's very boring. This is the rate of NAS. In this paper, they do call it NAS from 2013 to 2020. And like Doctor said, this was the time period that I started residency that we were seeing this rise. And over the past couple of years, we've kind of seen a downfall and then a level off. We're still collecting data to see how the pandemic in the last couple of years have been. And for the state of Tennessee, I was really interested to see this, that 62% of infants diagnosed with NAS were exposed to medication-assisted treatment. Most commonly in our state, that's buprenorphine for treatment of substance use disorder. And then even greater, so not only were most babies exposed to medication-assisted treatment, but when they looked at all legally prescribed medications, that number went up to 65%. And then for babies that had NAS with exposure to only prescription drugs, that was from medication-assisted treatment. I will caution you that I'm a doctor and I should describe something as prescribed or unprescribed. I don't describe things as illegal or legal or call something a street drug. Those are terms that I feel like law enforcement and judges and police should use. And as a doctor, I really should be saying at least one prescribed medication and take the word legally out there. That introduces some bias, and these will stay with our babies. That if you continue to read their medical record and I don't know, you're an outpatient pediatrician and this baby comes to you and it says they were exposed to street Subutex versus their mother was prescribed buprenorphine for medication-assisted treatment, that can really introduce some bias in the way that you look at your patients when you take care of them. So I would encourage you to take out legal judgments from your documentation. And this is just the graph of what I just described. These bars go down by year, with the red bar to the blue bar being 2017 to 2020. This is the percent, and this is non-mutually exclusive. So babies could have more than one of these, but you can see the really longest bars are in medication-assisted treatment with 62% in the year 2022. we can see that there's a small downtrend over the past couple of years. And for that downtrend, something else has to be increasing. And so we've seen an increase in the amount of heroin as the cause of NAS, as well as other non-prescription substances, which could include unprescribed fentanyl and other opioids. If you want to look at a map of Tennessee, you would not be surprised that our area of the state is most heavily affected. And in these particular counties, this is the number of live births that had an NAS diagnosis during hospitalization. For Northeast Tennessee and Sullivan County is 57 per 1,000. And in this Northeast area, it was 32 per 1,000. So we have a significant burden of this illness in our community. And then this even further breaks it down. The only reason I included this slide, I thought it was really interesting, is they suppressed cases that had, or counties that had less than 9 cases. And there's this Johnson County up here. I thought that was really interesting that there are counties that are very close to us that have less than 10 cases, whereas in our county and our immediate neighboring counties, we have greater than 30 some cases per 1,000 babies every year. So part about making or being involved in this research and talking about it is that nomenclature is really fraught. Opioid use in pregnancy can lead to withdrawal syndrome in newborns shortly after birth. This is in previous literature, it may refer to that as NAS. Traditionally, it's been called NAS, but more recent literature is calling it neonatal opioid withdrawal syndrome. And that's also how federal agencies, including the FDA, are referring to this. And if you ask why this is important, or how I like to think about it, is NAS versus NOWS is like opioid versus opiate. Opiates are a subset of opioids, and not all opioids are opiates. Same thing with NAS and NOWS. Not all NAS are NOWS cases. NAS is the spectrum of clinical manifestations seen in babies due to withdrawal from intrauterine substance exposure. NOWS is specific to opioid exposure. And from the data that I previously showed you, this is the vast majority of NAS cases that we are taking care of in Tennessee. Another reason for why this matters, and if you want to know what neonatologists do on their night off at approximately 9 p.m., the group of us are emailing and discussing second line agents for the treatment of neonatal opioid withdrawal. And I was surprised that we had some disagreement. But the most important thing when I show this slide is environmental and supportive measures are most important. These are doing things that control environmental stimuli around a baby, things like swaddling, breastfeeding, therapeutic massage, skin to skin, and these need to be absolutely maximized regardless of whether it's NAS or neonatal opioid withdrawal. But the reason that this nomenclature matters, particularly to me, is that neonatal abstinence syndrome with intrauterine exposure to opioids, if it is severe and requires pharmacologic treatment, it should be treated with opioids. Everything in the literature agrees that some sort of opioid is the first line agent. It depends on the institution, whether they're using morphine or buprenorphine. There are actually a few hospitals that even use methadone in babies that have neonatal opioid withdrawal. There's no consensus on this, but opioids is the first line treatment for refractory and severe neonatal opioid withdrawal syndrome. For a baby that has NAS and they've never been exposed to opioids and they've been exposed to amphetamines or cocaine or methamphetamine, those medications that are in the stimulant class, if you give them an opioid for their NAS, you are just sedating them. You are not treating their opioid withdrawal. They have no opioid receptors that are used to being exposed to opioid. And so by giving them an opioid, you're just sedating them. There's lots of research coming out on clonidine. I would refer to the consensus statement and clinical report that came out in 2020 that recommends using clonidine as a second line agent for the known neurodevelopmental effects of phenobarbital, and multiple animal models showing toxicity to the brain of neonates being exposed to phenobarbital. And then benzodiazepines are not typically used in the treatment of neonatal opioid withdrawal. So this is why this is important, is those babies that you're giving postnatal opioids to, they should have neonatal opioid withdrawal syndrome. So this is my main question. This is what I'm most interested in. Does pharmacologic treatment of neonatal opioid withdrawal syndrome affect long-term developmental outcomes? If you look at most NAS research that's out there, it largely focuses on maternal substance abuse. Should this mom take Subutex or Suboxone? Should we try to discontinue her medication during pregnancy? There's a lot of research out there on different withdrawal scoring systems. There's a Finnegan scoring system. I think it's absolutely fraught and has a lot of inter-rater reliability errors, or inter-rater reliability difference. There are other methods looking at taking away some of those things from the Finnegan scoring and only looking at parts of them, like the NAS score system that only looks at 9 parts of Finnegan scoring. And then there's the Eat, Sleep, Console systems. A lot of this research really is looking at the decision to treat versus don't treat with pharmacologic meds and decreasing length of stay. In the phenobarbital versus clonidine discussion, we were largely talking about length of stay compared to the two. And I would caution you, especially in this topic, about the importance of length of stay and the drive that's really high to decrease it. That the impact of various methods of treatment, pharmacologic and non-pharmacologic, having the outcome for early childhood is unclear. So what research is out there? This is a very interesting paper. I would also recommend everyone looking at this. It's the Prenatal Opioid Exposure, Neurodevelopmental Consequences, and Future Research Priorities. This was published in 2019 in the Journal of Pediatrics. And I would just like to have something that hides these numbers and ask you what you thought these numbers would be, the number of publications. And it's absolutely stunning, like 4, 8, 16. I would imagine a 0 or 2 zeros on the other side of this. That until the 2015, there were less than 10 papers per year published on the neurodevelopmental consequences of intrauterine opioid exposure. And in the totality of this, from 1975 to 2019, there were only 52 papers published. I think that's absolutely absurd and ridiculous, and it creates a lot of problems for pediatricians who have to counsel families whose babies have been exposed to opioids in utero. Looking at these, when they look at neurodevelopmental consequences, so this is a compilation of all 52 of those studies, this is really hard for me to interpret because it's looking at it kind of lumps neurodevelopment into 4 different areas: cognition, behavior, executive function, and language. And then the number of papers that found a difference. So the dark lines are, yes, there's an effect. No, there isn't an effect. And I sit there and I looked at this, and this is actually looking at studies of children with prenatal opioid exposure. This has nothing to do with children with neonatal opioid withdrawal or NAS. This is just, were you exposed or were you not exposed? And in the kids that were exposed, the evidence is mixed. They're saying in lots of these papers, in the few 52 papers that exist, that there's no effect in cognition in infants that are exposed to intrauterine opioids versus not. However, they did find a difference in behavior, and they did find a difference in language. I just started, as soon as I opened this paper, there's a long list of all the different studies that are available. This is one of the ones that is more robust. It's a case control study that looked at mothers who were compliant with methadone treatment programs, and it matched them with 103 women who had no history of substance abuse, as well as they directly tested those women, and they had a negative drug screen. It looked at children at 18 and 36 months, and infants and preschool aged kids who were exposed to opioids in utero had poor cognitive outcomes, but not with psychomotor outcomes compared to unexposed children. And then preschool aged children exposed to opioids had significantly lower adaptive behavior and language scores compared with unexposed preschool aged children. And so I'm looking at this and I'm trying to find, what's it going to say about NAS or, opioid withdrawal. And in the vast majority of these studies, they don't even address that. They just look like, were you exposed or were you not exposed? And this is a kind of graph of that. And when I first saw this graph, I was very surprised and thought it was just outstanding that the number of publications on children with prenatal opioid exposure in which neonatal opioid withdrawal was looked at as an outcome, the majority of them did not look at did the baby have NAS or did the baby not have NAS? And the number that look at infancy and early childhood, there are just 15 papers published in 2019 looking at the history of all of medicine for the entirety of humanity. Just 15 papers are looking at the early childhood outcome in infancy and those preschool age kids. It's a little bit easier to do outcomes with the newborn period, and this might be looking at did this baby get morphine or not, or looking at different scoring systems, that sort of thing. So the paper published in Pediatrics, if you ask it, what do we know about children with neonatal opioid withdrawal? It says this very helpful statement. Children exposed to opioids and diagnosed with neonatal opioid withdrawal may have poorer neurodevelopmental outcomes compared with their exposed counterparts that were not diagnosed with neonatal opioid withdrawal syndrome. I was like, wow, thanks. That is so helpful. Thank you for concluding that. For going back to looking at those papers that did look at it, those 15 papers, I wanted to see what was out there. And the first one they list is like my age. It was published in 1986. And you can tell basically just looking at the language of this, the development of children of drug addicts. I don't think in general people are publishing papers with that get accepted with that sort of title these days. And this was a paper from babies that were born in the 70s and early 80s, whose mothers were in methadone treatment programs, 70 exposed and 70 matched controls. And they did find that children that were exposed to methadone had lower scores on intelligence. And those that developed neonatal opioid withdrawal had lower IQ scores and adaptive scores compared to babies that didn't have opioid withdrawal postnatally. This was another one that I included because I feel like it's got to be fascinating to pediatricians. This looks at reasons for rehospitalization in children who had NAS, and it looks from birth to adolescence. And even by the time these children are adolescents, they have a higher likelihood to be hospitalized for behavioral disorders. So in our area, we see a lot more children who have a recorded diagnosis of NAS or neonatal opioid withdrawal. We're going to be able to expect a higher burden of need for inpatient hospitalizations for behavioral and psychiatric health disorders in our patient population. This was another one that I thought was interesting that was decently well designed as a cross-sectional study. This one was from 2013. It had a small number of patients, 25, but they did a good job controlling for polysubstance abuse, as well as also included nicotine in their sub-analysis. And this one found there's no verbal IQ difference between prenatal medication-assisted treatment exposure and the general population. But then it found that there was one standard deviation below the general population in performance IQ, memory, and motor scores. But their overall big conclusion from this paper was there was no difference in IQ between children with and without NAS or a NAS diagnosis. So this leads to my research. It is publication pending. And the title of it is Early Childhood Outcomes After Prenatal Opioid Exposure and Postnatal Neonatal Opioid Withdrawal Treatment. I don't have to read that title out loud very long, but it always trips me up, and maybe I should come up with a different title. So my objective was to evaluate early childhood developmental outcomes of opioid exposed infants in those that were treated with pharmacologic measures and those that were treated with non-pharmacologic measures. The vast majority of the literature that is out there is similar to my study. They were observational and retrospective. And the study population were substance exposed infants that were referred to follow-up clinic, and these babies needed to have at least a 12-month visit. We collected demographics, as most studies do. We also looked at the results of infant-derived toxicology specimens, as well as details of their hospitalization, including length of stay, what treatment they received, and what the infant's diet was. At the 12-month visit, I also looked at the developmental scores as well as guardianship changes. My primary outcome was the ages and stages questionnaire, and then the secondary was guardianship and breast milk diet. Where in North Carolina, where I did this study, our NICU follow-up clinic routinely saw high-risk infants that were referred to hospital discharge much like you expect your, 24-weekers, your extremely premature babies. But we also, all substance exposed infants that were born at Brenner Children's Hospital and the local community NICU, was a level 3 NICU, were referred to this clinic if they had any intrauterine substance exposure. And for all of our babies that were in this clinic, we did ASQ 6, 12, 18 months. But I didn't do anything different to the infants that were in the study. We included infants that had a prenatal opioid exposure that were referred to clinic and that they completed the 12-month visit. We excluded preemies and we excluded babies that had complex medical conditions. This might be a genetic syndrome, an anomaly, or a cardiac defect. There were no infants that had incomplete data that had a visit. And you can tell why this was very challenging for me. So when I got IRB approval in fall 2019, I had never heard of COVID and could never imagine that they're like, great, starting next year, January 1, you can start collecting data, that the outpatient clinic would be extremely affected by the COVID-19 pandemic. This was only medical record data, and we didn't collect anything besides what was obtained from the newborn hospitalization and the routine clinic visits. In general, we had 75 to 100 opioid exposed patients referred to clinic every year. And so only 44 were able to be seen during that time period. And there was a 48% no-show rate or reschedule rate during that time period. My primary outcome was ages and stages, and I also looked at breast milk provision and guardianship changes and how those two things affected neurodevelopmental scores at 12 months. For the analytic plan, we did descriptive statistics for the demographic data. We had multiple logistic regression to compare opioid exposed infants that required pharmacologic treatment with those that were infants that did not require pharmacologic treatment. The model was adjusted for race, gender, and gestational age, and then that sub-analysis with guardianship and breast milk provision. So these are the data for the infants that were in this study. There were 44 of them. It was a decent split on male versus female. 30 of the 44 babies received a postnatal opioid. At the Children's Hospital, we did Finnegan scoring and scheduled morphine, much like we do here at Niswonger. At the level 3 community hospital, they use postnatal buprenorphine. And so that's why I was designing the study. I wanted to compare morphine to buprenorphine, but COVID happened and provided a limitation with the amount of clinic visits that were going to happen. For race and demographic data, there were more Caucasian babies than African-American babies. And this is self-reported race. I thought it was really interesting that 11 of the mothers reported that their baby's race was other. That may be that the baby is biracial or they didn't want to otherwise identify. Asian was an option and it was not selected on any of the babies. And then non-Hispanic versus Hispanic. Prior to this, I had not cared for a Hispanic baby who had neonatal opioid withdrawal. So we can look to see that there are emerging different groups of patients in different demographics that may not have historically had the same incidence of neonatal opioid withdrawal. And then 14 of these babies received maternal breast milk during hospitalization, 14 of 44. And 2 of these women were able to maintain exclusive breastfeeding to 12 months of life. So when you're taking care of these women who have opioid use disorder and they want to breastfeed, you cannot discount them and you have to encourage that as strongly as possible. Our average length of stay was 19 days, but it ranged between 4 and 80. And like I was saying, there was 2 different hospitals that were involved. One of them used morphine monotherapy. The other one used buprenorphine. There were only 9 babies that had buprenorphine exposure, but there were 30 that got a postnatal opioid and the majority of them were morphine. This is the clinical characteristics of the babies. This column are babies that got that postnatal opioid, the postnatal morphine, and these are the babies that got non-pharmacologic treatment. These are the babies that are hanging out, newborn nursery, get to go home, day of life 4 or 5. We're like, you can go. Your withdrawal symptoms are not so severe that they are affecting your baby's ability to function, your baby's ability to eat, and it's safe for you to go home. So I do know that there probably were more babies in the community that were monitored for NAS that did not come to this clinic. And I think that's potentially a source of bias, that you have a baby, they're in the newborn nursery, they're fine. Do you really want to take your baby to a clinic and have someone say, okay, now there's a problem? So for babies that didn't get that inpatient treatment or have a prolonged hospitalization, not that many of them came to the clinic. But this was, our male to female ratio was statistically significant. And then with our race and ethnicity, those were not statistically significant. This number right here is 0.05, and I don't know where it is. And this was maternal breast milk at discharge, that 71% of the babies that went home from the hospital that did not need morphine or buprenorphine, a postnatal medication, were receiving breast milk. And only 13% of those babies that were receiving a postnatal opioid that needed that scheduled treatment, the minority of them were receiving breast milk inpatient. This is reported maternal tobacco use. I feel like maybe I see more families smoking here, but I also may have bias in that I have to walk by them to get to my car every day when I'm going home from work. And this is reported. There may be women that smoke and don't say, hey, I smoke cigarettes while I'm pregnant. This was maternal marijuana use, and this was based off of biochemical studies, those urine and cord toxicology studies. Babies that got postnatal opioids, babies that got on that scheduled morphine, they were a lot more likely to be exposed to marijuana in utero, that they had more severe withdrawal symptoms after birth that required treatment than the babies that did not get exposed to maternal marijuana. Our gestational ages were pretty similar, and our birth weights were pretty similar as well. This slide was very disheartening because you want to see a difference, right? You want to see all those babies that were better, that had less severe courses, that they're going to have better ASQ scores. So ASQ is the Ages and Stages questionnaire, and looks at 5 different domains of childhood development. Those include communication, gross motor, fine motor, problem solving, and personal social. There was nothing significantly different. And if you look at these numbers, they're not that different between the babies that got opioids and the babies that did not get opioids after birth. So I was kind of sad that I didn't see anything there. And then in my sub-analysis, if I had one slide for my whole grand rounds presentation, this would be that slide. And I realize it's busy and it's got a lot of numbers on it. But if you just look at these 2 columns right here, these are babies that got scheduled opioids after birth, that they had severe enough neonatal opioid withdrawal that they needed a scheduled medication. And if you look at the communication scores, sorry, not the communication scores, the gross motor scores. The best score you can get on an ASQ is a 60. So that means for every single thing, you're like, absolutely, my baby can do this. And I feel like the gross motor score is the best thing that I can do. The lie detector, like sometimes moms will tell you, hey, my baby can do all these things. And you go meet the baby and you're like, really, can they do those things? But most certainly you can see babies are pulling to stand and rolling over, and you can assess their gross motor pretty well. So every single baby that got opioids in the hospital and got maternal breast milk during their newborn period had a perfect score for gross motor. And those babies who got the postnatal opioids and did not get maternal breast milk, they had lower gross motor scores. And that was very statistically significant. It was also significant for problem solving as well. Babies that got breast milk and scheduled morphine in the newborn nursery or NICU or wherever they were located had higher problem solving scores. If you look over here for the postnatal non-pharmacologic treatment, so these babies were in the hospital, 4 or 5, 6 days, ruled out from needing that scheduled medication, ruled out from needing postnatal morphine. If they got so there are more babies in this category that got breast milk. And when they were discharged, The babies who got breast milk and never needed morphine or an opioid in the newborn nursery had a significantly higher communication score. It was less than 0.01. The babies who did not require morphine in the newborn nursery and went home without any breast milk provision, their communication score was 32. And when you're in the high 20s, low 30s, I might consider referring you to speech therapy, audiologic evaluation. That babies in the clinic that had a difference that wasn't completely normal, I would be like, we should probably do an evaluation and investigation here. And so I had a bias, and I thought babies that it's not that bad when they're in the hospital and they go home from the hospital and they never needed morphine, that they're going to do better and maybe have a better neurodevelopmental outcome. That was just a bias or hypothesis on my that I just personally had. And I was really shocked when this data showed that babies that did not need postnatal medications, that did not get breast milk, had such a significant reduction in their communication skills at 12 months. We also saw that for personal and social skills. It was p-value 0.01. Again, babies did not get breast milk in the hospital and did not get opioids. They had a significant delay or reduction in their personal social skills at 12 months compared to babies that got maternal breast milk. You can tell, and I don't think that this, I think we all expect this, that in babies that receive breast milk in every single category, the developmental scores were higher. But I was really surprised to see the difference between those babies that didn't get treated in the hospital and those that did. What could I be missing here? What would anyone think? There's got to be a bias or something that I'm missing that you could explain. Well, oh, that's why these babies right here, these 26 babies, these 4 babies didn't get maternal breast milk. That would be polysubstance exposure. So you might be like, oh, these babies were ruled out. The babies that got that did not need postnatal treatment were not the polysubstance exposure babies. The polysubstance exposure babies got postnatal opioid treatment compared to these. So this was, you can't say that polysubstance exposure is why these babies didn't get breast milk. I thought that was really interesting as well. Does anybody have any questions about this slide? I think this is the best slide that I have. Dr. Owens. How do you filter out the family of this, status, education, access to healthcare? Absolutely. How does that? Yeah. So for Dr. Owens, the one of the criticisms I got on a attempted publication was not publishing socioeconomic status. We did a chart review, and at that time, we were only able to see 20 of the payers, and 20 out of 20 charts were all Medicaid patients. So none of these babies were privately insured, and you can, in a way, use that as a proxy for socioeconomic status. One of the big limitations of my research is maternal education was only reported for 17 of the moms. And we know that maternal education is huge in determining neurodevelopmental outcomes for children. So that's a great point.
Rachel, awesome. Just a quick question. I haven't seen the Black infant getting the NAS because I think there is something in the genetics that they don't get it. So you're 14% who receive the treatment. That's little different than what so far I have seen in the literature. I don't know if you want to comment, but you guys have done a great job with the ASQ score and sub-analysis. And I think the breast milk and importance of the breast milk is very well known, but I think in the NAS even it's more. So kudos to you guys all for bringing again the same point again and importance of it.
I'm going to be honest, I had a really hard time understanding what Dr. Shah said.
So basically, I was just trying to say is that you have done a great job, Rachel, looking at the outcome and a sub-outcome of the communications and other things with those who have received and those who have not received the breast milk. So that's great because we all know the importance of breast milk, and that's the reason that American Academy of Pediatric recommends that continuing of the breast milk even for the NAS. So that's one thing. But then importance of language development, I think you really need to highlight that point because I don't think so. I have seen that point in the literature. So that's a great. Only my question was, I have not seen the African American population getting the NAS in your study. You have a 14% that got NAS, which is kind of against some of the genetics that they usually don't get it. So I'm just curious to know you guys have any theory or you have any explanation for that. Thank you.
Absolutely. One thing we were looking at in our local area about NAS and African American patients is that African American women have a lower referral rate to medication assisted treatment, and they have lower access to medication assisted treatment. And so there are fewer African American women who be maintained on pregnancy or during pregnancy on these medications. In terms of epigenetics, I have not seen that data. That's really fascinating. I would love to see that. We thought I was also worried about racial disparities, like maybe elsewhere in pediatrics, we see there's a pediatric emergency room studies, there are pediatric sickle cell studies that show that physicians provide lower amounts of opioids to African American children than they do to Caucasian children. And so I was interested to see if we were treating more babies who were Caucasian with postnatal opioids than African American children. There were only 6 African American children in my study, and it was 50-50. 3 of them got scheduled opioids, 3 of them did not. But absolutely, we need to look at socioeconomic status and other confounding factors, particularly access to maternal care and particularly maternal access to addiction care may have a disparity based off of race. That's a really good point that I meant to mention on this slide.
From what I have heard, and I have to still look at the literature, but there is something in the genetics that there is a reason that African American, they usually don't get high on opioid compared to the Caucasian. And I think there is some data available. I'm not available for any literature that I have myself reviewed it, but that's something I've heard over a period of the times in lots of different talks and different of the studies. But that's something is out there. But I think that may be the one of the reason. But also what you said point is very well taken. That usually you're right. There is a racial disparity, and so many times the different racial people they don't get the adequate pain management and other treatment. So that point is also very well, good explanation. Thank you.
I think Dr. Starkey has a question.
Yeah, I was just curious how many of the babies went home with foster families versus
I'm so excited that you asked that because that's probably the next slide. Yes, so this was like one of the hardest things. I'm sorry?
You repeat his question.
Oh, he asked about how many of these babies went home with their parents and how many of these babies went into CPS or another type of custodianship pattern. This was really hard for me. 2 of the moms of baby that were in that had opioid use disorder died of overdose during their child's NICU stay when I was in fellowship. These children were not included in the study because they were both extremely premature. And one thing that was, I have stats on Tennessee and North Carolina. We'll get to that next. But for parents, 21 of my 44 babies went home with biologic parents or birth parents, and 23 of the babies went into CPS or kinship care. The kinship care might be a grandparent. CPS is some other custodian, whether they were a foster family, but I put them together, that they did not go back in the same home. So that means in North Carolina, or at least in this study that I did for a year and a half, the majority of the babies did not go home with their families. And when I looked at 12 months, there was a change, and this is huge, and this largely contributes to adverse childhood events. 5 of these 21 babies had a change in their guardianship in the first 12 months if they were discharged with a parent. Can anyone guess the reasons why? Relapse, incarceration, basically maternal incarceration, relapse. And in these, I did not know this particular mom, but one of the moms died from opioid overdose. And one of them switched from mom to dad at 12 months, that mom could no longer care for the baby. They were separated. None of the babies that were discharged to someone who wasn't their parent were reunited at 1 year of life. 0. None of these babies got to go back into their mother's care in their first 12 months of life. So this is a huge area. And if you're a pediatrician taking care of children in this region and taking care of children who have intrauterine opioid exposure, this has to be on your priorities of documentation and follow-up, and really that's huge. That 5 of 21 babies had a custodianship in their first year of life. And we know that those adverse childhood events, especially the earlier that they occur, the worse outcomes that these children are going to have in a multitude of lifelong health risks, obesity, diabetes, psychiatric disorders, future substance abuse in these babies. So I appreciate your question. That was something that I was really interested in. None of the breastfeeding mothers lost custody of their children and did not have a guardianship change. So this is the numbers for the state of Tennessee. There are over 6,000 children. This is available at aap.org, opioid fact sheets. These are interesting to look at as well. And over 6,000 children were placed in foster care. This is data from 2016. 11% were infants, and in 29% of those babies, parental substance abuse was the reason or a factor in the baby being removed from their parents' care. I compared Tennessee and North Carolina. There were fewer children that were placed in foster care, but more of them were infants, and more of them were related to parental substance abuse. In all of the children that were in all 5 of these babies, parental substance abuse was a factor. The reason they were reincarcerated, the reason for death, the reason for losing custody of their children was parental substance abuse. This is the bottom of both pages. They look exactly the same in Tennessee and North Carolina. Medicaid paid 81% of the $1.5 billion that hospitals bill for treating babies suffering from opioid withdrawal. This is a huge driver in what can we do to reduce length of stay, is because length of stay costs money. My worry is that reducing the number of babies that receive postnatal opioids could have an effect in neurodevelopmental outcomes. If you'll look in this group, the babies that went home earliest from the hospital, those babies that went home day 4, day 5, this group right here had the lowest communication scores and lowest personal social scores. So we have to ask ourselves, which babies do we treat? Which babies do we not treat? And is really length of stay, is that the most important thing? Often, to a lot of people, it is. Often saving billions of dollars is obviously a important and reasonable goal. But my worry is our focus on this in ways promotes us as pediatricians to try not to treat babies. And I would encourage you, if you feel like a baby needs to be treated, to treat them. Things that are advocated that we can do is to create policies that prioritize prevention and allow children to remain safely with their families during treatment. There was a House bill in North Carolina that was introduced in 2019 that listed maternal substance abuse during pregnancy as a way to expedite DCS involvement and removal of children from the home. So we have to be mindful about the policies that we create and how they affect these children. As pediatricians, we need tools to recognize and treat and support children and their parents affected by trauma to lessen the lifelong impact and promote healthy families. And we need to ensure families have real and timely access to services through Medicaid and other prevention and treatment programs. Again, for the babies that I was able to see who their payers were, 20 of 20, 100% were Medicaid patients. And so moving towards policy changes that reduce access to Medicaid to these women and their children may not be in their best neurodevelopmental interest. So there are limitations to my study, retrospective design. And then just like Dr. Owens mentioned, some of the maternal data that I really, really wanted and tried really hard, like I dug in their chart as far as I could. And if it's like, oh, this would have like the place that they worked or what they did, I really tried to find maternal education, was only able to get about half the moms. And then a lot of people are like, why does this matter? We're moving towards eat, sleep, console. We're moving towards ways to reduce the amount of babies that receive opioids. And I hear that and understand that. That was the institution that I worked at was improving its efforts to implement ESC and have fewer babies receive any postnatal opioids. And again, this is a promising treatment modality, but the neurodevelopmental effects of ESC versus standard Finnegan scoring and giving morphine based off of that is unknown. We have no idea if lengthening or shortening the hospital stay is neurodevelopmentally advantageous for these babies. And we don't know that reducing the amount of postnatal morphine exposure to these babies, if that's in their interest or not in terms of their long-term outcomes. I think this is a really great starting point that whenever you're doing any sort of research thing, that the inherent bias that you come in with and you're like, oh, I know this to be true. The babies that didn't withdraw are going to do better and be more fine, and maybe have even counseled families that way in the past. That there are things that we just don't know until we do that research. And there's not a lot of it out there. So anybody that's interested in these things, I'd be happy to work with you in any way. We also know that there are some infants that have severe neonatal opioid withdrawal that require scheduled postnatal opioids, that they're, even if we maximize ESC and we get really good at it and we get really awesome at environmental measures, there still will be some babies that will need pharmacologic treatment. And we need these additional studies to help determine their developmental outcomes and help provide anticipatory guidance for their families. All right, so that's my last slide.